Scott, are you making any headway or can you hear us?
I think I just got it.
Okay, very good.
I
Scott,
apologize for that.
okay, good. Scott, you have the floor, so go ahead and take it away. Thank you.
Thank you, Mr. Chairman. I apologize that technical error on my side. Thanks for having me present this morning. My name is Scott Bruner. I'm the Deputy Secretary of Hospitals and Facilities at KDADS. And I'm going to work from two different documents this morning. One that's a PowerPoint deck that the first slide has the title and your committee name. I'll walk through those slides. And then there's a second document that's a spreadsheet that's titled at the top, KDAD's House Bill 2016 COVID Allocation Facility List. I'll talk about that here in just a couple of minutes or refer back to it when I get done. But I'm going to start on the PowerPoint presentation if that's okay. So I'm going to go to the second slide. So again, my name's Scott Bruner, and thanks for letting me be here today. What I wanted to share with you today was respond a little bit to the comments from the conferees you heard from yesterday, and describe what KDADS has been doing in responding to the COVID-19 pandemic since you all adjourned last spring. I wanted to focus on really four areas of our activities working with adult care homes and people living in long-term care settings in Kansas. And those four topics are incorporating and disseminating federal guidance that's come out for adult care homes in Kansas, applying that federal guidance to adult care homes that are only licensed by the state or only have a state license, requesting and distributing CARES Act funds to adult care homes and other long-term care settings in Kansas, and then finally implementing the provisions of House Bill 2016 for personal protective equipment and infection control supplies. I realized after I put the slide deck together and went through the presentation, I don't exactly follow that sequence. But I'll get to all those topics, and so beg your forgiveness for not following them in the stepwise fashion. The other comment I wanted to make before I got into the meat of the presentation was to kind of describe the role of KDADS in the long-term care world in Kansas. We really have two roles. One is providing policy guidance and reimbursement guidance for long-term care settings, nursing facilities, assisted livings, other kinds of long-term care settings. That's really our policy making role. Those activities are overseen by my counterpart, Deputy Secretary Janice DeBoer, and her team that work on the kind of policy reimbursement side. The other part that we work on is really a regulatory function, doing surveys and oversight, implementing Kansas regulations. And that's where the commissions that I oversee step in on more on the regulation side. So more of what you'll hear from me today is kind of that regulatory survey perspective. But we do have that other role as well, and I'll try to cover as much of that as possible. There may be some areas of that I'm not the expert in, and we need to have Janice kind of weigh in at another time. But I did want to set, so we've got both the policy making and the regulatory function, and you'll see how those things have kind of interacted through this description. If you can go to the third slide, then it's titled. It's really a timeline of actions that have happened since COVID-19. We wanted to document for all of you by the timing of as things rolled out, kind of what we learned from the federal government as we were learning about the virus, and how we responded to that. So maybe just to start on the third slide, March 4th, CMS, the federal agency that oversees Medicare and Medicaid, suspended all non-emergency surveys of nursing facilities, redirected our activities to just working on focused infection control surveys. So our regulatory function in the long-term care setting is guided by our agreement with the Centers for Medicare and Medicaid Services. And when they tell us go do A, B, and C, we go do A, B, and C. And so that early in the pandemic, they said, stop doing regular surveys and focus on infection control. Shortly after that, on March the 9th, CMS directed nursing facilities to close their doors to visitors, outside services, and non-essential healthcare personnel, which you heard about yesterday. It was a huge step to control the spread of the virus inside facilities, and that became part of our focus too to help implement that those activities. I didn't have the exact date, but sometime shortly after that, we followed the executive order that the governor issued that allowed us to give temporary permission to nursing facilities to set up temporary space in their buildings to cohort and isolate people that had COVID-19 within their current license or their current footprint. We let them have some temporary flexibility in how they could use their space. And then by March 13th, we'd issued, CMS had updated their guidance in more detail about who could be restricted inside facilities and how the buildings could use their space. That was kind of the first month, already a pretty significant change in what we were doing. On the fourth slide, kind of goes through the rest of the summer. By April 29th, we issued recommendations on reporting for COVID-19 positive residents to KDADS and to KDHE, and to reinforce some guidance that CMS had issued. By May 18th, CMS issued a long document described as how facilities could start the process of reopening to visitors. Much of that, those recommendations were hard to implement because at that same time, the virus was spreading across the country and within Kansas. So the kind of initial condition to reopen was that the level of community spread wouldn't be very high, which wasn't the case. But we did use that CMS guidance to issue some corresponding guidance to state licensed facilities, which is what I referenced there on June the 12th, where we tried to take the CMS guidance and apply it to other facilities that are licensed only by the state of Kansas. Tried to really pull together a lot of the guidance that had happened before that point to have one document that nursing facilities, adult care homes, long-term care settings could follow with all of those provisions. And we've got references to that document in other parts of the slide presentation. On slide 5, kind of how this all fits together for our regulatory functions. Like I said, our role as the state survey agency is to survey, go in and inspect long-term adult care homes to ensure they're following federal guidance and applicable state regulations. And we do that under direction of CMS for a good chunk of the facilities in Kansas, nursing homes in particular. What CMS did early in the pandemic was say, stop your regular annual reviews of nursing facilities and focus on ensuring that facilities are following all of the recommendations of CDC and CMS on infection control. And so we shifted to that function pretty quickly once we were released to actually go into facilities. For some length of time, 45 days or so, we were just told not to go into any facilities at all. But once we could restart our activities, that's what we focused on. So on the fifth slide there, I put together a chart of our kind of the count by week of our survey activity in these settings, and I put the guidance document that what we're following from CMS at the top of that slide, so you can follow
Scott, I hate to interrupt for just a minute, but
Sure.
We've had some difficulties for the committee members on having access to your slideshow, and I just received word that that is available online now under miscellaneous committee members. So if you'd like to take just a minute to find that and pull that up. Sorry, Scott, it wasn't on your end, it's on our end.
No, I apologize. I should have paused.
No, you're fine. So we wanted to hear what you had going. So I think everybody should have that now. So just give us a couple seconds, Scott, and then go ahead and proceed.
It gives me a chance to pull it up in full screen so I can actually read the numbers, because I printed it off a little smaller than I can read from.
Scott?
Xavier, I'm sorry, I didn't see your comment until just now. I apologize for that.
Scott, do you have the ability to share your screen?
I can.
Okay, would you mind doing that for us?
Happy to do it.
Okay, thank you.
Hopefully you can see the slide deck. Let me see if I can do it as a slideshow. So,
Scott, we can see it, so you're
okay.
good.
Well, let me just leave it there if that's okay. So my page numbers will be off because this is the draft I was working from. But so on this, which is your slide 5, shows the table I was talking about. So in blue are the number of federal infection control surveys. That's what FICS stands for. And so those are the facilities that we were told by CMS to go in and investigate or do a infection control survey in, and CMS defines that list. And so back to July, you can see that number was a little bit below 10. That's the blue bar. The orange bar are the number of immediate jeopardy complaint surveys that we completed. So the kind of 2 core things that we had to keep doing at the direction of CMS were federally infection control surveys, and when we got a complaint about a condition in a facility that would create an immediate jeopardy of harm for an individual living there. So that's the orange bar. And you can see back in July, it was kind of under 10 and creeped up. But then right around Thanksgiving, that number jumped of the federal infection control surveys jumped into the 40s and then was over 60 for a few weeks. That's because, and one of your conferees mentioned it yesterday, CMS was required state survey agencies to go out to facilities and re-inspect when there was if we'd already done a survey, we had to re-inspect. If they'd had an outbreak or a new case in a facility, we had to re-inspect within 3 to 5 days after that outbreak was reported. And kind of that time frame in November was when outbreaks were very common. So what the conference mentioned yesterday about the number of surveys that were being conducted, there were a lot being conducted at that time. Many of them were re-reviews because that's where we were directed by CMS to go. But I think that graph kind of shows the prioritization and how things rolled forward. So on slide 6, just to kind of capture that overall activity. So by September 23rd, we'd inspected 329 nursing facilities for infection control policies. We'd actually conducted 513 of those federal infection control surveys. That included initial reviews and some re-reviews of all facilities. And then we put the counts here of other investigations that we'd completed. House Bill 2016 also required us to complete infection control surveys of all licensed adult care homes in Kansas. And so this was part of that requirement, but we also had a federal requirement to do that. The bullets at the bottom are our current priorities from CMS to do infection control surveys and complaint surveys. So that's what we're working on today. Here on slide, this would be your slide 7. For adult, other what we call state licensed facilities, assisted livings, home pluses, residential healthcare facilities that aren't subject to the federal requirements. We did, under House Bill 2016, conduct infection control surveys there as well. By that September 23rd date, we completed 179 of those in home plus and adult daycare settings, and 293 in assisted living or residential healthcare facilities. So we got to all of those facilities over the course of from about early in July, late June until September 23rd. So everybody had been inspected. Every facility had had one visit from one of our surveyors to walk through their infection control policies and do other reviews. But at the same time, we were also investigating complaints and other citations that may happen from there. So I did want to show some of the other guidance documents that we issued. So I mentioned in June, we issued a guidance document to describe the process of reopening, apply those CMS guidelines to state facilities, and try to pull some of these things together. I put the link where you can find that at the bottom of the slide. The other reason I wanted to pause here for just a minute, one of the conferees yesterday talked about reporting of cases. And that was a question that came up quite a bit early in the pandemic of if we've got a resident or a staff member who we suspect it has COVID-19, who do we tell? And we tried to clarify in that process, pull together the federal guidance, the state guidance, the current state law, and narrow that down. So in the third bullet point there, if you had a positive case in your facility that had to be reported to the Department of Health and Environment, that's part of their statute to have a case reported within 4 hours of identification. And then it also had to be reported if you're a nursing facility to a system called the NHSN, or the National Healthcare Safety Network. We had regulatory authority to also require reporting to KDADs, but we waived that for this purpose because we thought we could get, we can get the information from the KDHE reporting. And so we did try to reduce the number of places where a facility would need to report or call something in. And KDHE's improved that process some too over time to make that more of a bulk upload rather than having to make a phone call or fax something in. So we did try to respond to that concern about who had to be reported to and how frequently that had to happen. On slide 9, the visitation guidance has come up in a number of different environments, so I did want to talk about it just briefly. So in September, mid-September, CMS took so CMS had directed that facilities needed to be closed to outside visitors and outside folks. By September, CMS acknowledged that that was having a huge impact on the well-being of residents. It was difficult to implement, and wanted to step back from that position and tried to clarify under what conditions a facility could open to visitors or have visitors in, and how to implement that. And so in that second paragraph there, as long as the community spread of COVID-19 was low and you had infection control practices in place and you could follow social distancing, and that facilities were testing as required, they could allow visitors into their facilities, and as long as they could still meet all those conditions. Not very many facilities could meet all of those immediately because the level of community spread was high and continues to be high. So that was difficult. The CMS guidance also authorized states to provide $3,000 grants to facilities to help them purchase plexiglass dividers or things to help create a separate space for visitation or to facilitate window visits or things like that. So there were some flexibilities that were introduced at that point. This is slide 10. So we issued corresponding guidance shortly after that document came out to again apply the visitation to facilities that are only licensed in Kansas. So our concern was that there was a set of federal rules that applied to nursing facilities and facilities that were licensed only by the state that maybe share a campus or are in the same location, and would have two different sets of rules. So we tried to marry those up. So the KDAD's visitation guidance said that you could do indoor visitation if there was no new onset of cases in the last 14 days and there was an outbreak level testing. Again, not very many facilities at the time we issued this could meet that condition, but it was there, and it's still in place to guide things going forward. The other thing we tried to clarify in our document was about compassionate care visits. So if a resident was having a declining condition, was in hospice care, really needed a visit from somebody to help with the transition to a nursing facility stay, a facility should work on getting a compassionate care visit. And we expanded using the federal definition, but expanded who could be part of that to family members or clergy or other people that the resident could really depend on. So again, we tried to mimic the federal guidance, but apply it in state settings as well. So I'm on slide 11 now. That came out on October the 19th. And we tried to say we recognize that that being closed to visitation is hard on residents, makes life difficult for them, and needed to really focus on what facilities could do that were good for residents and people in facilities. and try to focus on the person's needs. Oh, sorry, too fast. And again, as long as the community spread was low and there were adequate infection control practices in place, facilities could work towards opening up to visitation. We've been asked a couple times in the last few weeks, as the vaccine's coming out, if there's any modification to this guidance. And at this point, the CMS requirement is still in place. So we think it's a little premature to recast any of this guidance. The procedures, the kind of steps to follow are still appropriate. But the vaccine might impact the level of community spread. We might be seeing some downward trends in that. So we think the guidance is good. We just need to, the conditions need to be more favorable to promote that going forward. Shifting gears just a little bit. So now I'm on slide 12. I did want to start talking about kind of what we were doing to distribute funds from the CARES Act through the Spark Recovery Office to long-term care settings. And so we, as an agency, as we move forward in describing our activities through the session, have been working on this slide to kind of count up all of the CARES Act money that's flown through, has flowed through Spark that we've been distributing. And this ties to the spreadsheet that I mentioned that looks at adult care homes specifically, but at least identifies the kind of big buckets of funds that we've been responsible for distributing. So we distributed $33.7 million to nursing facilities directly for really unencumbered about what they could use the money for, but for COVID-related expenses. We've distributed $18.9 million to state licensed facilities and nursing facilities for personal protective equipment related to House Bill 2016. We're almost done with all of the funds that have been allocated to KDADS for that purpose. We've got a little bit more to go after a couple of targeted distributions, but that's where we are today at 18.9 million. We've distributed 19.2 million to behavioral health providers, 1.1 million for communication devices and visitation equipment to multiple community-based providers. So within the federal guidance, we were able to buy tablets or give grants to facilities to buy tablets to help with televideo visits between residents and their family members. And that in total added up to over $1 million. And then $7.8 million for community-based providers for protective equipment and other communication devices along the way. A little outside the scope of today, but we did want to show you that we're capturing all of those funds. So focusing specifically on House Bill 2016, I'm on slide 13 now. When House Bill 2016 passed, again, we were directed to provide necessary personal protective equipment, sanitizing supplies, and testing kits. Won't read through the rest of this, but we formed an interagency work group to figure out what the supply chain looked like, where we could go to get that equipment, how to implement that provision. We met for the first time on June the 12th, and made a couple of key decisions. One of them was that for testing supplies, those were all flowing through at the time the Kansas Department of Health and Environment lab and any other outside, and they were processing many of the tests that were happening. So they wanted to use their supplies, and there was an established mechanism to do that through the Department of Emergency Management and the lab directly. So we kind of took testing out of the mix of this distribution, and then we needed to find a vendor that could help fulfill some of the orders. Was the main task. On the next slide 14, we did contact a number of vendors that had been supplying this kind of equipment through emergency management. We came to an agreement with one of those vendors to be our intermediary. They were making purchases from manufacturers, and facilities could order directly from that contractor, and then they would fulfill the orders. So it was a fulfillment contract that we entered over the summer, July, August. Losing track of the time now, but we entered into that agreement to have that fulfillment vendor in place. Then we had to allocate the funds, or we requested funds from the Spark Committee to implement that requirement. We built that budget for state licensed facilities only. So nursing facilities were getting funds from Spark and that 33.7 million that was already identified, and they were getting some funds directly from the federal government. The group that wasn't getting any additional help for COVID-19 were those state licensed facilities, assisted livings, home pluses, residential healthcare facilities, homes like that. So we targeted the effort initially at those homes and came up with a fixed dollar amount of $225 per month per bed. And at the time, there were 2.5 months left in the year to distribute those funds. So we built the budget around those numbers. We received approval from Spark on October the 1st for that initial is $10.2 million, I believe. Maybe it might have been closer to 12. We got that money on October the 1st. The vendor stood up their website on October the 13th, and the first orders were processed that week. And we ran that portal for orders, let facilities know how much money they had available, all the way through right before the Christmas holiday. December 22nd is when we turned the portal off. The other key thing to know is that facilities didn't have to provide any money at all to get those supplies or to guarantee them. They made an order based on a pre-approved set of supplies that were available. The products were shipped either directly from the manufacturer or from our vendor to the facilities at no cost to them for shipping or anything else. The other limitation, just for simplicity, was that that same vendor wasn't able to take a separate order. The facilities couldn't pay cash or use their own funds to buy from that vendor. This was only for Spark funded activities. So that was a little complicated early on, but we got through that fairly quickly, and facilities were able to get their orders fulfilled. Again, all the way through, and some things are still being shipped, but all the way through the end of December. So now I'm on to slide 15. So on November the 20th, Spark authorized additional funding to KDADS for PPE that would apply to skilled nursing facilities. So a different group of facilities than originally authorized. Because of the timing was a little different and the needs were higher in nursing facilities, the amount per bed was higher as well. We allocated $350 per bed to try to, and again, given the timing of the money, we had about 5 weeks to spend it. So we allocated that, and we issued them at the end of November. So in total, when you add all that together, it's a little over $18 million to provide roughly 2.5 months worth of supplies, the state license, and about 5 weeks worth of supplies to nursing facilities. That included gloves, gowns, masks, N95 masks, and near the last month or so, we added cleaning and sanitation supplies to the mix as well. So all those were available throughout the ordering process for House Bill 2016. On slide 4, so I did want to talk just a minute about testing, because that's come up in our Bethel testimony over the summer, and just to kind of get everybody on the same page. So at testing, the federal government, CMS, issued a directive over the summer that nursing facilities needed to test their staff on a regular basis, starting over the summer, to detect COVID-19 in the facilities, and then continue that. And it's continued since they issued that directive in the fall. To implement that, the federal government sent testing instruments to nursing facilities in Kansas, so they could conduct rapid tests at the point of care in their facility. And so this first slide, number 16, describes that process. So the Health and Human, but the purpose of HHS sending those machines out to facilities was to help implement the testing requirement that was coming shortly after the instruments were distributed. So they were sent out. There were 2 different types, the BD Veritor or a Quidel Sophia 2. Most of our facilities in Kansas got a BD Veritor, but there are a few Quidel machines out and around. They were sent out in 3 different waves, one in July, one in August, and then one in November to clean up some facilities that didn't get them in the earlier phases, and they were free. The instrument and the testing kits that go in to actually perform the test, those were all provided directly by Health and Human Services facilities. 319 nursing facilities received one of these devices by November 19th. That hasn't changed since November 19th. And they received enough supplies to complete one round of tests, and then they needed to reorder those testing kits or cartridges from the manufacturer going forward. There were some problems in the supply chain early on that the test kits weren't, or resupplies weren't available. So CMS took a second step, or HHS took a second step that's described here on slide 17 about another way to do the rapid testing using an Abbott Binax Now card, which you can see a picture of it there on the slide. So the Operation Warp Speed, HHS, and the White House purchased 150 million of these tests, and then began shipping them directly to facilities the week of September the 21st. These went to nursing facilities and assisted living facilities, so a little bit broader group than the instruments. They are a simplified test that requires a nasal swab. You complete the test inside the kit itself, and it gives you the result. And that supply that every facility receives is supposed to fill in the gaps of their need until they can get more supplies through their testing instruments. And I've got at the bottom there, 113,000 cards have been distributed to 106 assisted living facilities in Kansas, and a little over 500,000 at the 264 nursing facilities. So these are two of the ways that facilities are able to complete the testing requirement that's in place. And then since then, the state's testing strategy has been in place as well to fill in some other gaps along the way. The other part, so on this slide number 18, is to talk about the testing frequency. So the number of times a week you have to test your staff in a assisted living or nursing facility is based on the county positivity rate. So the higher that the rate of positive tests is in your county means the more frequently you test. For many of the last 8 weeks or so, facilities have been having to test twice a week. They're staffed twice a week based on county positivity. That's changing a little bit now. It's improving. But we, in the CMS guidance that implemented this and our corresponding guidance at the state level, we pointed facilities to the KDHE report on county positivity, which looks like what's on this slide, number 19, and shows by color. If you're in a red county, you're testing twice a week. If you're in a yellow county, you're testing once a week. And if you're in a green county, you're testing once a month. And again, that updates with testing results as they come out. But that we're able to use this data directly from the KDHE website. We pointed facilities to that, and then to update that on a regular basis going forward from there. So I think I captured the four things of what we've been trying to implement in terms of the federal guidance and applying it to the state level, distributing funds from the SPARK process and CARES Act, and then House Bill 2016, both some of the testing elements and the PPE elements. And again, we shared a spreadsheet with all of you that describes, tries to capture those funds. I'm happy to talk about that if you have questions about what's on that spreadsheet. It's a big spreadsheet. It has a lot of information on it. It may require a little bit of description, but I do want to pause if there are questions, Mr. Chairman, if that's appropriate now, or I can briefly describe the spreadsheet and then open to questions, whatever you prefer.
Thank you, Scott. I think we will go ahead and pause just for a minute to see if any of the committee members have any questions. And committee will open it up for questions at this time. Senator Thompson.
Thank you, Mr. Chair. Thank you, Scott, for your report. I'm glad you provided the spreadsheet. Is there a spot, I'm trying to look on the spreadsheet, that gives us totals? Because from what it looks like, we received a total of $80.7 million in SPARK money. And does that account for all of that $80.7 million on that spreadsheet?
This spreadsheet does not, Senator. the rows on this spreadsheet are adult care homes, nursing facilities, assisted living. So for the community-based providers or mental health centers, they're not reflected on a row here. So if you add up the columns, they're not going to hit the total. We did try to put in the very top row, it's labeled approved / allocated. That row at the top should add up to that $80 million to show by function and round of funding what was happening. But again, the rows are just adult care homes, so we'd leave out some of the providers that received Spark money, like the mental health centers, some centers for independent living, community-based providers that just aren't reflected on this sheet.
Okay, and so the approved and allocated is divided up per sheet, so we'd have to go through and do the math on that, basically. It looks like at the top of each sheet, there's approved and allocated, and then versus what was paid.
The approved
I guess
allocated
what
should
I'm
be the
saying
same
is-
on each sheet.
Yeah, it might be kind of nice to get a just kind of a totals
Okay.
type of sheet or something, so we can, see the overall. But I appreciate the spreadsheet, shows where all that money went. Thank you, Mr. Chair.
Senator Steffen?
Thank you, Chairman. As you looked at how you would assist these nursing homes, did the CDC or the ks.gov ever discuss, recommend, or institute, or even consider any oral pharmacological prophylaxis? And if so, what? Thank you.
Senator, I'm not aware of any recommendation that came out like that. KDHE might. I told the Bethel committee the lane I'm trying to stay in is kind of the regulatory side for survey and some of the other guidance. I'm desperately trying to stay out of the public health. Now, I'm not a medical professional, so I don't want to give anybody medical advice. So but I'm not aware of anything. But I can ask our colleagues at KDHE and see if they've heard of anything like that. But I'm not aware of any.
That'd be great. I'd love to hear back. Thank you.
Senator Gossage?
Just a quick question. We heard from a conferee yesterday that the gowns were less than par that they received. Have you heard anything about that, and has any of that been addressed?
So thank you for raising that question, Senator. I did want to try to address it. There were a couple of moving parts, and I wasn't sure from listening to the conferee which one he was referring to, but the federal government did send packages, bundles to nursing facilities of supplies, and the dates run together, but over the summer. And we heard, and Linda Mowbray and others on the trade association side had examples of these gowns, and they were largely trash bags with holes cut in them. But those came from the federal government. The ones that we've distributed through the portal, the PPE portal, are all as we identified products. We worked with our vendor to say we need things that these facilities can use. So, and they looked for suppliers that could provide, and they're broken down by level. But we provided level 1, level 2, and level 3 gowns. So at level 3, it's a full surgical gown like you would see in a hospital. Level 1 is a little less it's less covering, a little more rigid, but it's definitely not a trash bag. So facilities could choose which of those they wanted to order based on what their need was. We didn't presume that. We did hear from one nursing facility chain that they ordered some of the level 1 gowns and they didn't meet their needs. They weren't protective enough. And so we did work with them to, I think we let them keep the inventory that they had, or they returned some of them. We refunded the money and let them buy the higher level gown, which they thought would be more appropriate. So we did hear some complaints about I guess it's the level. I mean, I think the quality was good. They weren't trash bags, but they weren't exactly what the facility wanted. We tried to put all that information out so they could see. For some of the cleaning products, we had the OSHA number and all the information that a facility would need to evaluate it. But we didn't hit that 100%, but we did try to correct where we heard about concerns to make sure facilities could get products that they could use and were comfortable with.
Thank you for that answer, and thank you, Mr. Chair.
Senator Petty.
Scott, thanks for the presentation. I know, and of course I've been on the Bob Bethel, so I've heard this before, but you know, a lot of the complaints has been about visitation and about testing. And so both of those have been, correct me if I'm wrong, but both of those have been driven by CMS guidelines. Is that correct?
Yes, that's correct.
So and you mentioned that if they had particularly when it comes to visitation, that in order to increase the amount of visitation, if they were going to have indoor, they had to have no cases in the last 14 days. Now, is that's still in place?
Yes, that's still the guideline in place. Yes.
If a facility has, so then does it become on the part of the individual facility to decide how stringent they want to be within that, or they can be more stringent, not less? Is that correct?
That's a fair statement. We wrote the guidance, well, to be consistent with what CMS had out there, but also to give facilities the flexibility of adapting to their individual circumstances. So for maybe a different example is if a facility had an area that was near the front of the building or near the main entrance that was isolated from other places that they could easily get people into and out of, they could be maybe less restrictive of indoor visitation than a facility that just didn't have that kind of space. So we didn't want to be, we tried to not be as prescriptive kind of one way or the other because we didn't want to second guess what facilities were able to do. We did ask them to think about their planning and how they would keep people safe, both visitors and residents and staff. So I think we were trying to be as permissive as we could, but then also letting facilities decide what they were comfortable doing in terms of visitation in their capacity to do that. The other concern that many facilities raised with us was, you know, if we have visitors in and the resident needs help communicating with their loved one or has a problem, that's going to take staff time. So we were also sensitive to this is going to be a demand on somebody's time to facilitate. We didn't want to second guess what facilities had available to do that as well. So I believe my best answer to your question is that we tried to be permissive as much as possible to let facilities set their own policies within those frameworks that we set up.
Thank you.
Scott, I just wanted to circle back onto the surveys because that seemed to be a pretty big issue with some of the nursing home facilities. One of the concerns that they had was the regulatory people coming in. They had no idea what their testing was, when the last time they were tested, or if they've even been tested. And that was a big concern for them because you have someone coming outside, coming into the facility. Can you speak on that, on maybe should we have better communication with the nursing facilities on that, or what's the best solution to that?
Best solution is a high bar. I'll tell you what we did. So we have altered. I don't think it's a big alteration, but we've clarified in our procedures that if a surveyor is entering a facility, they need to be in full protective equipment. So that means gowns, gloves, N95 mask, and a face shield in most cases. So that's to make sure that our surveyors are protected from anything they might be exposed to, and there isn't any contamination from the surveyor going out. So that's the base that we've set up and have had in place. I think surveyors also wanted to be protective, so they would vary that a little bit, but we said that's the standard. If you're going into a facility, you need to be in full PPE. The other thing, we've been working on a testing approach for our surveyors. We've been trying, the difficulty was figuring out where we actually go and get tested. And then how do we communicate that back to facilities. So surveyors, when they are in their work week, they could be in multiple facilities during the week. They start on Monday, they end their work week on Thursday. And we were trying to figure out what day do we test them? Do you test before they go into facilities or after? So we've been working through that. And we've got one last hurdle to overcome before we can start our process of routinely testing surveyors before they start their work week and can show that they're either COVID negative or they've passed that level of screening. We understand the concern. I guess the other part, I mean, CMS has never, we follow CMS's guidance. They've never directed us to require testing of surveyors. So we said, well, that's okay, but we want to make sure our folks are protected and we're safe. We followed all the screening procedures for facilities before we enter, and then we're going in full PPE. So I think that's the right position to be in. But we are, I'm hoping by next week we'll be testing surveyors every week before they enter facilities. We've got Binax cards from the KDHE lab to do that. The surveyors are all nurses; they can test themselves. We've got a little bit of, they've got to be observed conducting the test on themselves, and we're trying to figure out how to do that. But after we get that done, we'll be testing surveyors on a regular basis before they enter.
Thank you, Scott. And did you just want to briefly touch on the spreadsheet again on
Sure,
that
sure.
handout, and then we'll wrap this up.
Happy to do that. So what the spreadsheet tries to do is by funding program or by round of Spark funding, what was distributed to adult care homes. So the listing of facilities, what's on every one of those pages are adult care homes by type, and you'll see that in column C is the facility type, and there should be, I can scroll down to I can't get to the bottom. Oh, there's an index at the bottom of what those acronyms stand for, and it's by county. And then as you work across, it's by different funding programs. So the first couple of columns are Spark funding for communication devices. That's what comm devices means. And by the time you get to column G, that's the funding that we distributed directly to nursing facilities that went based on their bed count. The PPE funding is in column I. And then the last piece that we added that's not a dollar amount are in columns L and M. So we wanted to show, when we did this kind of prompted by a Bethel committee request, there were questions about testing and who had capacity for testing. So in column L, that shows the number of the Binax testing cards that each of those facilities has received based on the federal reporting. And then in column M is how many test kits facilities received to run through the instruments they got from the federal government. So those last two columns are not dollar amounts, they're counts of how many, essentially how many tests a facility could perform. So, and as the earlier senator mentioned, the amounts across the top in that first row, approved and allocated, try to reflect all of the Spark money that we received. But again, you'll only see on this spreadsheet adult care homes and how much they individually received. So we hope this is a useful tool to show by facility how much CARES Act money each facility received related to these activities. They're a little varied. Again, if there's more description that you need, we're happy to do that. But we were really excited and appreciate the staff at KDADS for pulling this together, because it does kind of show gaps, which is one thing that we were looking for over the summer or in the fall, but also kind of the total impact that the CARES Act has had on many of these facilities.
Thank you very much, Scott. Committee, do we have any questions on the spreadsheet? Senator Petty.
Thank you. So Scott, just so I understand this, so if you see a care facility that has nothing, then that means they weren't in this category.
If it shows nothing, they were eligible to receive some amount of money, or they're licensed in our database. They may not be a current facility. There are a couple on here that are no longer licensed. Some of them declined. Of the $33.7 million, that funding, the facility had to attest back to us that they would use the money for COVID-related purposes in their facility, and some declined that, so they're at zero. But I wouldn't say they're all either they couldn't participate or didn't participate, or our list is dated by a couple of months of current licensed facilities.
So either they don't have a current licensed facility, or they couldn't participate, or chose not to participate.
Yes.
Thank you.
Scott, I don't see any further questions from the committee. Thank you very much for taking the time to come in or by virtual testimony, giving us a spreadsheet and going over it. I know this has been a project for quite a while, and we appreciate you giving us an update. Committee, I would just quickly give you an update. Tuesday, we did have KDHE scheduled to come in. They were not able to come in, so they are wanting to reschedule for a joint committee meeting on the 19th with the House Health and Human Services Committee from 12 to 1. So we are working on that, and it looks like tentatively we will be having a joint session or committee meeting hearing with KDHE on COVID vaccinations and testing on January 19th from 12 to 1. As soon as we find out rooms and more specifics, we'll let you know. Senator O'Shea.
Thank you. If that were to be the case, would we still have our morning meeting at 8:30?
Yes, we would.
Okay, thank you.
You're welcome. All right, committee, no further questions and no further business to come before the committee. We are adjourned. Thank you.
Thank you.